Good evening, everybody. I'm Dr. Moushumi from Rajiv Gandhi Cancer Institute and Research Center. First of all, I'd like to thank Dr. Sudeep and Dr. Shona for giving me this opportunity. I will be discussing two papers. And before I start discussing the papers, so I would like to discuss the concept of polygenic risk score. And for that, I have few slides in the beginning. So we all know that there are high risk genes and moderate risk genes in breast cancer. There are no low risk genes in breast cancer, but there are some variations which can have some association or increase the risk of breast cancer. The high risk genes are your genes like BRCA1 and BRCA2, and the moderate may be like ATM, PALB2, or CHEK2. So then again, the other concept is that in breast cancer, it is not one disease. So there are groups which are ER positive, they're ER negative, and triple negative, and each of them can have a different risk, absolute risk associated with the genes which are of high risk or moderate risk. Then the other concept is that the risk of the patient is different for different age groups. Say, for example, in this graph, you can see that the patient who is BRCA1 positive may have practically minimal risk in the earlier years, and as the age increases, the risk of the patient also increases. Then the concept of single nucleotide polymorphisms. This, as we all know, are the nucleotide variations which are present in all of us and which make us all different. They are different for certain races. And because of these variations, the different mechanisms may have a different speed or processing in the body. And why these variations are important? Because these variations, some of them can be associated with the different increased risk of breast cancer. And individually, we all have more than 3 million SNPs, and having more and more SNPs which are associated with breast cancer risk will add the cumulative risk of breast cancer in a patient. So for this, how do we do this? We do this with gene-wide association studies. So what are gene-wide association studies? These are large-scale observational studies comparing SNPs in the affected versus the unaffected population. These are patients who are in thousands and thousands, and their risks are compared. So a patient who has few SNPs which increase the risk of breast cancer will be at lesser risk compared to a patient who has more SNPs. In fact, the concept of SNPs is very, very important in the patients in prostate cancer patients who have a very minimal risk from the main pathogenic genes, but a lot of risk from these SNPs. And this concept is also coming to breast cancer. So this is, I told you about the high risk, high risk genes, the moderate risk genes, and then about the variations. So these variations or SNPs can add to the high risk or the moderate risk and alter their overall risk. So why it becomes important is that you know that BRCA genes like BRCA1, BRCA2, TP53 are already high risk genes. So we know we have to screen them or do mastectomy or all sorts of them. But the genes which are moderate risk, we don't know how they are moving. So if we have these SNPs which are adding to these moderate risk genes and these polygenic scores which is generated from these SNPs, and they add to the moderate risk gene, will overall influence how we screen these patients and how we manage these patients. So then another concept in the polygenic risk score is that of the percentile. So usually we are talking of the average risk, but here it does not make much sense to just talk about the average risk. We need to talk about the risk at a 10 percentile or maybe 90 or different percentiles, because the risk varies with the percentile and the variation may be up to 60%. So between 10% and 20 percentile. Then coming to the main article. So this is published in Journal of Clinical Oncology in 2021. It is the risk of breast cancer among carriers of pathogenic variants in breast cancer predisposing genes varies by polygenic score. So here again, around 27,000 patients are there on one side, and around 26,000 controls are there, and these are the genes which are tested, and there are around 105 single nucleotide polymorphism. So again, just telling you the genes. So these are BRCA1, BRCA2, ATM, CHEK2, PALB2, BRAD1, BRIP1, CDH1, and NF1. And then the ER subtypes were also specified initially. An estimated 5-year and lifetime absolute risks were calculated across percentiles. As I told, it is important. Then the risk in the patients with carriers having a family history and without a family history. Here only first degree relatives were considered, and 105 SNPs were analyzed. So these are the various studies from which the cases were taken. And then this is the adjusted odds ratio across one standard deviation and the mean, and it is seen to fall every 10 years. And these are the only genes which had a significant findings, that is the BRCA1, BRCA2, ATM, CHEK2, and PALB2. So it could be seen that the risk varied from 10 percentile to 90th percentile. Say in non-carriers, it varied from 6.7% to 18.3% respectively. So this is the concept. It is a continuum. It is not one thing. So whatever you talk, you have to talk with different age groups and in different percentiles. So, and then what it really brought about is that the patients whose polygenic risk score had more than 25%, 20% risk was significant, because that is 20% is the cutoff where the American guidelines for screening, for MRI screening and mastectomy is set up. So there were these genes which had these more, and you can see that BRCA1, BRCA2 are already high risk genes, and these SNPs do not actually add much to their change in their screening practices. But the other genes like ATM and PALB2, if the SNP scores are added, and especially with the family history, you can see that their percentage, the polygenic score is really influences them. So you need to this information of polygenic screen will definitely add to decision of when they have to be screened or not. So this is the same thing. You can see that these are the patients who have the family history and those who do not. And the patients who have the family history have definitely have the more 5-year absolute risk of breast cancer compared to the ones who don't. And BRCA1 and BRCA2 stand apart. They already have more than 50%. So you need to look at patients, the genes where the risk is increased more than 20%. So these are the genes which are increased more than 20%. And what comes in those category are your ATM and CHEK2, mainly ATM and CHEK2, and to some extent maybe PALB2. So this is what we conclude from this study. The limitations again from this study is only 105 SNPs were examined, and it had only European females, and there was no statistical significance for ER negative cases because the cases were limited. And so it could not be calculated, and sample size could have been larger, and only the first degree relatives were examined. So what we know is that maybe probably just because of calculating the polygenic risk score, ATM genes like ATM and CHEK2, if they have pathogenic variants there, you can decide on their screening procedure. So you can alter that. So what questions are still to be answered? So are these polygenic risk scores going to be added to the high risk gene for risk assessment? Yes, in future, but it may take 5 to 10 years. When it will be added. Will these be absolute? No, they will not be absolute, because there are so many other factors like environmental and a detailed family history, which you cannot always do. So yes, but they will definitely help us to decide which patients are to be screened and which patients have to be taken to for mastectomy in especially the moderate risk genes. So coming to the second paper. So the second paper, it's a relatively easier one. The germline pathogenic variants in cancer predisposing position genes among women with invasive lobular carcinoma. So every time we have been talking about the invasive ductal carcinoma. So this is a study which are discussing about the invasive lobular carcinoma. Again, it has thousands of patients. So it has around 3,000 patients of lobular carcinoma and a population-based cohort also of almost same or slightly more number. And then these are the 9 genes which are compared. So these are the 9 genes which are compared, and then they are compared between ILC and the IDC population. And what is found is, so again, these are taken from the Carriers Consortium, and these are the 9 genes, and especially in check 2, this particular variant, that is the C470 T2C, is compared because this has been published in some of the studies to be associated with ILC. So what they found is that the median age for ILC lobular carcinoma was 54 years in the clinical cohort and 64 years in the population cohort, and 95% of the patients were ER positive and HER2 negative. So, and what they found is in the pathogenic variants in the lobular carcinomas were 65% in the clinical cohort and almost the same in the population cohort. The variation which they say is because of the data keeping, and the pathogenic variants among lobular and the ductal were also similar in both the cohorts, and CDH1 was tenfold found in the lobular carcinoma compared to the ductal carcinoma. BRCA1 was significantly reduced in the lobular carcinoma compared to the ductal carcinoma. Then PAL-B2 was seen lesser in the lobular than the ductal, and the pathogenic variants like the CHEK2, BRCA2, and ATM had more than 1% population presence in the lobular carcinoma. So this is again almost the same thing in a different format. So pathogenic variants of BRCA2, CDH1, and CHEK2 were significantly enriched in the lobular carcinoma. So what they're trying to say is BRCA1 is usually not seen in the lobular carcinoma, but BRCA2, CDH1, and CHEK2 can be. And this particular variant CHEK2, which I mentioned earlier, which was in the earlier studies, was not seen in this particular study to be associated with lobular carcinoma. And the patient with CDH1, which have more lobular carcinoma, 50% of them either had a personal history or were associated with gastric cancer also. Then there were certain other observations that there were other genes which were not clinically significant, which were associated. Then ATM was had pathogenic variants was associated with ER positive lobular carcinoma. So that's a known observation which was repeated in this particular study. This again, the limitations of this study were they had a smaller sample size, and the clinical cohort included women from different clinical studies, and probably there could have been mismatch in this thing. And to conclude, then of course BRCA1 is lesser important, but BRCA2, CHEK2, and ATM are important. But while screening, I feel the overall message is the histology is not that important, and you have to look for all the genes, whatever the histology, IDC or lobular carcinoma. With that, I would like to thank you for the patient listening.